तो फोन मारा मैंने आपको भेजा है ना, हम भेज दिए सर। तो वो ठीक करो उसके बाद जो ये है, ये एक हैप्पी है मेरे साथ। ये आपके साथ जो भी कोऑर्डिनेट करना है ना, टैगिंग वैगिंग के लिए और जो भी और सिविल भी, मैंने उनको समझा दिया। हर टॉक के बाद, प्रेजेंटेशन के बाद वो वी ट्रांसफर से उसको अपलोड कर देंगे। लिंक आप उसको भेज देना थ्रू सुनना, वहाँ पर उसका वो वीडियो बना के वीडियो आगे प्रेजेंटेशन करके अपलोड कर देगा यूट्यूब चैनल को, लिंक कर देगा। हेलो, हाँ सुना जी, मैंने एक्टिविटी कर दी, एक बार चेक कर लो आप। हाँ ठीक है, वही लगता है सीधा। नहीं एक बार लाइव हो जाए ना स्क्रीन थोड़ा सा, लिंक भी नहीं भेजा सर। मैंने अभी लिंक मैंने कर दिया है अपनी, और थोड़ा मुझे फोन मार लो, एक बार चेक करेंगे थोड़ा जैसे प्रोग्राम कौन सी टीवी पे चलाओगे और वो कहाँ चलाओगे? वो है अपने टाइमर चलेगा जैसे भी होगा। और ये इनका इंट्रोडक्शन कहाँ चल रहा है? फैकल्टी का इंट्रोडक्शन दिया था मैंने, फॉरवर्ड किया था इंट्रोडक्शन में टी में आ रहा है, मुझे टी वाला चलेगा नहीं चलेगा, दूसरा वाला तो चल जाएगा। कौन सा? तो वाला भी दिया है। हाँ वो तो टीवी दे रखा ना। हाँ हाँ वो चला दो, चला दो ना, किससे चला रहा है? चला रहा है, चला दो ठीक है। उनका नहीं चल रहा है, टी नहीं चलेगा सर मेरे पास, टी नहीं चलेगा मेरे पास। इसका पासवर्ड चाहिए क्या? नहीं सर, वो एक्चुअली मैक का होता है सॉफ्टवेयर सर, तो वो थोड़ा सा दिक्कत है।
Good morning everyone. First of all, I would like to welcome all of you for this ISPNS live operative pain workshop being conducted at Ramlinga Swami Boardroom on 14th or 15th of September 2023. First of all, I would like to welcome our Honorable Chief Guest, Professor A.K. Mahapatra sir, for coming from far off and giving us his precious time. I would like to welcome our operating faculty today, Professor Professor G.P. Dureja and Professor Ashish Tandon, who has spared time out of their busy schedule and come to teach all of us. Now to start with our first session. First session is based on the basics of session of this pain workshop, and this pain workshop is a more sort of rather than surgery, it's a highly minimally invasive intervention based session, requiring a lot of gadgets and which many of us are not familiar with. That's why we plan to have a introduction session to start with about all these gadgets, how to use them, what are their basics. So coming with the this basic session, first talk is by Professor G.P. Dureja sir. First of all, I would like to request Professor A.K. Mahapatra sir to chair this session. Can I request Professor Mahapatra sir to come and also I would like to request Professor Deepak Agarwal sir to kindly chair the session along with Professor Mahapatra sir. Also I request Professor Ashish Bindra madam to kindly come to the dais and chair the session. Yes. Sir, he's spoken to me. Dr. Ramesh has arrived. Bindra madam, please. First talk is by Professor Dureja sir, and topic of the talk is assessment of neck and back pain. May I request Professor Dureja sir to kindly come to the podium and start his presentation.
Can we have the slide on the big screen? Yes. Big screen. Yeah. Thank you very much, Dr. Rajiv, for inviting me. It's indeed a privilege and a privilege to be back to my alma mater, All India Institute, where I spent 21 years, long 21 years, and it's about 38 years now since I joined, and now 21 years I worked and lived, and I always consider this as one of the biggest temple rather, and every evening I go back home in front of AIMS and I bow my head in front of this institution. It's such a great institution, and anybody who has a privilege of working here, I think it's a great thing to work in this institution, because whatever I am today is all because of this big institution, All India Institute of Medical Sciences. Only thing is that when I talk to people now, I have to classify AIMS New Delhi rather than anything else, because when I left it was only New Delhi, but there are plenty of AIMS now. So the life has gone a full circle now. The mission which I started in All India Institute of Medical Sciences almost 37 years ago, we started a full-fledged pain clinic. We used to have some pain clinics in neuro anesthesia department, but we started a full-fledged pain clinic, and the mission was to have it as a holistic approach to pain and involve all the specialties. So I think the dream has come true today now, with everybody realizing that pain management is not somebody's one domain, but it is everybody's domain, and I cannot call it pain management as my domain, but it is a multi-speciality, and I think this is a true forum where we are now sort of encompassing the facets of pain management. I'll be talking about challenges of back pain and neck pain, and we don't have figures from our country, but it is a challenging issue. Every day you see so many patients of back pain, and we don't have any prevalence data, but almost 75 to 80% of adult population at some point of life will suffer from back or neck pain, and the worst is that 45 to 75% of these patients will continue to have this for at least for 12 months after they started pain. So it's a very, very important thing. Why I'm standing here and talking about a very basic thing like clinical assessment of back and neck pain is that almost 65% of our daily load in our centers, in my center rather, are patients suffering from back and leg pain. Now, you being clinicians and neurosurgeons coming from various institutions, you have a different sort of a perspective in terms of back and leg pain. We as pain clinicians have a different perspective because we get patients with 24 hours of back pain or leg pain. You get patients in the OPD with so many MRIs and all things, but we as primary pain physicians get patients who had a back pain at night or a neck pain in the morning, and he comes to you running. So the responsibility as a clinician is much more, and the assessment has to be perfect, because I, being the first contact of that patient who is suffering from back pain or neck pain and hand pain, has to find out whether this patient has the pathology of pain, the etiology of pain, and whether the neurological examination of this person, whether he has any deficit, etc., which requires an immediate intervention. I am the first contact who will decide whether an MRI is needed or whether any other investigation is needed, or a conservative management. So if I put him on conservative management, it is my prerogative and my responsibility towards that patient. So seeing a patient for the first time and seeing a patient with so many MRIs makes a lot of difference, because to a neurosurgeon, he comes to you for an opinion whether surgery is required or not. To me, he comes for the diagnosis of pain, for finding out whether there is any deficit, etc., and that's more responsible. So my next 15 minutes will be focused towards the basic things. So you may think it is basic, but it is very, very important. And of course, the statistics say that it's more disability than cancer plus heart disease plus stroke plus AIDS, and lots of money was spent. Now, we always say aging gracefully, but with this back and leg pain, we are now saying aging painfully. This is one figure which I got from the 2nd September editorial of Economist. So most of these magazines now are focusing on very important aspect of back and leg pain, and this particular figure is from United States, which shows that 65 to 84% of age group, 30% of patients are suffering from chronic pain, back and leg pain, and almost 10% have pain limiting their daily activities. So this is a very alarming figure. This is from US, developed country. You can imagine if you these figures in India would be much more. So 65 to 85 would be about 40% of population which would be suffering from back pain and leg pain, and almost 30% would be suffering from disability because of that. So no more aging gracefully, it is aging painfully, but it is the responsibility of people sitting here to make this aging gracefully from aging painfully. Another editorial from Economist. So I'm talking about a lot of emphasis by people across the globe on back and neck pain, and this says that vast sums of treatment money is wasted on treatments of back pain. I mean, like, so much emphasis is being put in, and if you read between the boxes that the doctors advise, I mean, like, a lot of focus on the doctors who are treating back pain and leg pain, that they are giving addictive drugs, they are quick to order an MRI. Yesterday I had a patient who had a 3-day-old pain and he comes with an MRI. So I asked him 3 times, you have a 3-day-old pain and you got an MRI with you? So every doctor is running to order the first MRI so that he doesn't miss the bus. And obviously there would be something in the MRI and patient gets disturbed and all those things. Then you can also read that the best treatment is non-medical, and they say that nobody orders, this is from Economist, so I'm not laying much stress on this, but what it says that there are a lot of treatments in the back itself. Spines are injected with cement, vertebrae are fused, discs are excised, tempered, yet unsurprisingly it is largely the pain mechanism is the problem. So we don't understand the pain mechanisms, and we end up with entities where even after fusion, patient comes to us with no pain or continuous recurrent pain. So these are issues which have to be addressed, and if you clinically assess a patient well, I think most of these things can be sort of controlled. Now, major concerns in back and leg pain are 4, and one is of course increased utilization of imaging studies where it is not required. We know that these tests are very sensitive. If I get an MRI, I get a small disc, I've never had a neck pain. I get a lumbar disc, which I never had a back pain. Opioids, you know about the opioid epidemic in the US, because any patient complaining of persistent chronic pain, they were prescribing opioids. Increased incidence of back surgery, of course you would all agree, but now of course the trend is going down. Use of spinal injections also, a normal MRI and we see an epidural being given or all those injections being given, that increases the cost of back pain, and of course there is no decrease in disability. So worst is that you do everything, but the disability still continues. These are figures from 2006 which shows that the lumbar fusion rate is going up and up, and of course the non-lumbar discectomies are not going up, but lumbar fusions are going up and up. This is 2003, this would be a very steep figure now in 2023. And not only that, even spinal injection, they are all covered by the insurance in US, and you see every patient who complains of back pain, they put in an epidural without even bothering to see whether it is a radiculopathy or it is any pathology which is giving pain, but yes, insurance covers, so shoot an injection. So, and nothing happens. Patient does not get any relief in pain, he gets more psychological disturbances, and that is what it happens. Now coming to the basic, what are the various back and neck pains which you generally get in your day-to-day clinical practice? So basically a myofascial pain, very high incidence of myofascial pain nowadays, young girls and boys working from home, bad posture, and I mean like 25 to 35-year patients on a Saturday, because I work on Saturday and Saturday is a holiday for them, they come in numbers and they have back pain, leg pain. I mean, I tell them that at your age I never visited a doctor, but what has happened? That's because of bad posture and all, and sensitization of nerves. So it's not a small entity, it is not a small muscle pain, it is a myofascial pain syndrome, which is because of overactivity of nerves causing muscle spasm, disability, and more psychological disturbances. And of course we all know as neurosurgeons and neurologists and pain physicians that back pain associated with disc bulges, spinal stenosis, facet joints arthropathy. Facet joint was one where not much focus was done in the past, but now everybody is realizing because of the day-to-day postural variances, there is a lot of incidence of facet joint. Fracture, infection, tumors, spondyloarthropathies, fibromyalgia. I mean, this is one condition where back pain comes, somatoform disorders where the back pain comes, and sometimes you get patients which is a referral pain from the viscera, like CA, pancreas or pelvic pain radiating to the back. And this is just to complete the figures that maximum of the mechanical pain, 15% is neurogenic pain, non-spinal conditions and visceral pain, and these are things. But very important to remember that back and neck pain are not simple nociceptive pain, not simple inflammatory pain. Gone are the days when we used to think that it's an inflammatory pain, give anti-inflammatory drugs and everything would be okay. Now it doesn't happen. It's a heterogeneous disorder. Right from day one, if the patient is coming with pain of 24 hours, it is not just a inflammatory pain, it is not just a nociceptive pain, it's a mixed type of pain. So that is why the treatment strategies have changed. We don't treat it as an inflammatory pain, we treat it as a mixed disorder where nociceptive, neuropathic, and central sensitization. So nociceptive, neuropathic from day one, but if it prolongs to 2-3 weeks, the sensitization also sets in. So very important that in your daily practice you have to categorize this pain, and it is not difficult. You have to just give some test or ask some question in the history, and you will come to know that if there is a neuropathic element, or if you touch the patient there is hyperalgesia, there is a central sensitization. So clinical assessment can make you be aware that it is not simple inflammatory pain, and this figure just tells you that there is a mix. Chronic, acute and back pain is a mix of central sensitization, nociceptive pain and neuropathic pain, and very important for us as clinicians because we have to treat it accordingly. Now the assessment, the real part of this story is the assessment has to be an algorithm approach. You cannot just tell the patient to lie down or see the MRI and decide. No. Gone are the days when you see the MRI, okay, there is a disc, go and get admitted, I am going to do the surgery. No. You have to take a detailed history, you have to do a detailed neurological examination, come to a diagnosis, find the pain generator, then only decide the treatment. So appropriate history taking. Of course in hospital we are very busy, we don't have time, but I have seen that in our practice or even neurosurgeon in private practice spend almost 1 to 1.5 hours. I mean patients come and tell us that I have to wait 9 hours One of my friend in Fort School, Anna Patil, he's a student from All India Institute of Medical Sciences, spends 1.5 hours on each patient examining. And such a team approach we have built that he will call me up and say, I think this patient doesn't need surgery. So this is what we had envisaged, that it should be a team approach. Every day I get a call from him, I'm sending one patient, or I call him to tell him that this is one patient which needs your expertise. So that is important. History taking, detailed neurological examination. So you have to be a basic clinician. If you don't have a hammer, please don't enter a OPD. You have to find out the sensory, motor and every examination. Imaging only when required, and we will come to that. Decision making important, and then of course rehabilitation very important. So focus history, all of you know, duration, intensity, distribution, radiation of pain, presence of paresthesia. Everything which I am telling you gives you some clue to the diagnosis. Paresthesia, neuropathic component. Radiation, maybe a compressive radiculopathy. Gait, I mean, I just, pain fellows were with me yesterday, and we had a patient who came with walking like this, a waddling gait. And I told them what it is. They immediately said, sir, it looks like cervical myelopathy. Patient never complained of pain in the neck. She was in Canada where vitamin D was being given for that particular treatment. She came here. She said, I don't have pain, I have come to you, but I have only paresthesia in my leg. So immediately we examined, and the reflexes were exaggerated. We did a simple test, Hoffman, which revealed that it is positive. Within an hour, we got the MRI done, and within next 2 hours, the patient was referred to the neurosurgeon. So this type of a medical care you won't get anywhere in the world. 2 months in Canada, nothing done, and 2 hours in India, the diagnosis was done. But it was the gait only which was telling us that this is a myelopathic gait. Relation of pain with postures, claudication, yes or no, morning stiffness. Morning stiffness is one very important symptom which tells us whether it is a spondyloarthropathy in a sacroiliac joint, or a myofascial pain, or a fibromyalgia. This pain will generally not manifest as a morning stiffness, but a pain because of inflammation, pain because of muscle spasm will manifest as this. Sleep disturbances, day-to-day life. These are important things, because sleep hygiene and effect on the day-to-day life is also a very important thing, consideration which you have to do. Job profile, we always ask them, sitting, if you have to sit for more than 20, don't sit for more than 20 minutes, bending forward, trauma, and all those things have to be taken into consideration. And if you want to be more specific, then history of cancer, the elevated ESR, unexplained weight loss, of course these are things which we would always ask, and I'm not going in detail about this. And the red flags, of course every clinician knows that these are the red flags which you have to ask, and you have to make the patient alert to. These red flags are not meant for us, but it is meant to be told to the patient that these are the red flags. If you have any of this, please rush to us, because if you have any pain which is causing any disturbance in passing urine, or there is all those things which are present, then you please rush to us. And these are the yellow flags. These are yellow flags which we generally don't lay much importance on. The psychosocial problems in the face, and patient may be anxious, patient may be depressed, and this is like a vicious circle. If there are yellow flags, the pain would get aggravated because of anxiety, and there would be more spasm, more pain. So these all things have to be outlined. And of course, very, very important, if you don't have this kit, this particular kit with you in your OPD or in your chamber, I think I particularly don't deserve to see a patient with back pain. So these are important, and we look for the motor elements. It is always nice to expose the patient, but in a busy OPD or with patients now with different social strata, they may not like to, but it is preferable that you give me some time, 5-7 minutes. So these are autonomic elements and all. I don't go into the details. You have to do all these reflexes to find the dermatomal level, C5, C6, C7. This is what I was telling you. If you have any clue that this patient may have myelopathy, just do this test, and you will immediately find and order a simple test. Heel tiptoe walking, these are simple tests, but they give you a lot of information. Heel toe tip walking can tell you about the deficit. Gait, as I mentioned, will tell you about the myelopathy. Flexion, aggravating in disc disease. Hyperextension, aggravating pain in a facet joint. SLRT, again the level of radiculopathies. Lasix test, again confirming that. Fabry's test for the sacroiliac, and sometimes you may find local examination. So these are the neurological levels which you can find out. L4 from this the knee jerk, L5 from the EHL, the ankle jerk, and by a good history you can find out the diagnosis definitely. And we are not even going for the examination. Back dominant pain aggravated by flexion, minor disc, extension, facet joint. Leg dominant pain aggravated by flexion, it's a nerve root. Walking extension, it's a central stenosis or claudication, which you said. So these are simple things which will help you in confirming your diagnosis. So just to end with a typical patient who comes to us, this is like a 57-year-old male with back pain for last 2 years. There are no specific inciting event. He doesn't say that I bent forward and did something. No associated leg pain, no neurological symptoms. Pain is slowly worsening over 2 years. So every point which I'm mentioning has some relevance, to the point of not being able to walk more than 2 to 3 blocks, and he says it's about 7 by 10 visual analog score. He continues to go playing golf but can't walk for more than 8 to 10 minutes, so he says I use a cart. Fine. But his passion is playing golf, and he says no, I'm not able to play golf. So this is like a very senior guy, administrator in a company, and he comes to you. Physically the job is not demanding, it's a sitting job, but he is not able to do what he wants to do. So you have to listen to the patient's story, obtain adequate medical history, social history, look for psychological and environmental factors that might impair the cause of pain. He says pain increases if I sit for more than 30 minutes. Again, offering some clue to the diagnosis. Slow progression of the symptoms, again offering some clue to the diagnosis. No history of all these things which I mentioned. This is a dermatomal distribution of pain. Anything about the diagnosis, please? Anyone can come forward to tell me what the diagnosis is. So we did a physical examination. We have a simple questionnaire which tells us that the pain is neuropathic. Yes, it was neuropathic. Patellar tendon reflexes were intact. SLRT was negative. Sensation intact. There was some hyperalgesia on touching the back. Again, some clue, please. Anybody can come to the diagnosis. Pardon, please? Fibromyalgia. Only back pain, not body pain. Only back pain. Yes. So pain increases on forward bending and also mild increase on hyperextension. Forward bending and hyperextension. There is a local tenderness at L5, and the patient has an antalgic gait, altered sleep pattern. He is anxious because at such a senior administrative job he is not able to do this. So this is a simple questionnaire, patient health PHQ-9, which tells us whether the patient has anxiety and depression. So you need not go into the detailed thing, just offer this questionnaire. Within 2 minutes you will come to know that how much is it affecting his psychology. Any laboratory tests? Yes, we did an X-ray which shows reduction in the space in L4, 5 and L5S1, and also the X-ray shows beautifully the facet joints, so it showed that there is a facet arthropathy. This was the imaging, so I just showed you one view, and you can see there are degenerated discs, there is an annulus tear, but the disc protrusion is not significant to touch any nerve. So all the blood tests were normal. So what could be the diagnosis? A non-specific back pain? No, it cannot be, because there were some disc bulges. Discogenic pain? Yes, maybe, probably. Facet arthropathy? Yes, maybe, probably. Radiculopathy? No. Any other thing? So this is a patient who has a degenerative disc disease and a facet arthropathy. So I have no right to push in for surgery. I have no right to give an injection. I have to manage it conservatively. And that is what we did. A second patient, another case study, 38-year-old athlete complaining of neck pain for last 3 years, and he is not able to perform his the sports which he is pursuing. Pain, he says, is more on sitting and extension of the neck. When he does the extension, more pain. Local examination reveals tenderness at right C4. Sharp movements of neck are very painful. Everything, all radiology is normal. Pain increases on neck extension. Anything on the diagnosis, please? Maybe. Pardon? Disc prolapse, no radiation of pain. So it's the facet joint which causes this pain, facet arthropathy. It is most underdiagnosed, but it is a very important cause, in particular in athletes who do violent exercises. Whiplash injuries, of course, and the trauma can lead on to this. Radiological findings are normal. It is the clinical history and examination which confirms the diagnosis. Bone scan, of course, who does a bone scan, can reveal arthropathy, but the most important to clinch the diagnosis is a diagnostic block of the cervical medial pons. So we did the cervical C4-5, C3-4 facet joint diagnostic block, and he had relief, so we did a RF ablation, and he is back to his sporting activities as he was doing earlier. So in terms of radiological studies, these are simple things which we do it, and imaging of the spine, then X-ray is basically not very useful, but in a mechanical back pain normal, but in like spondylolysis, spondylolisthesis and vertebral fracture. These are the indications of this. Or if you want to see the facet joints, and X-ray may be useful. You can see a stenosis also, you can see the listhesis also in an X-ray. So plain radiograph is recommended in compression fractures or those with osteoporosis. CT is very good for seeing the bony structures, so myelography, post-myelography, CT scan. When we didn't have an MRI, we were relying mainly on the CT, myelography. MRI very good for seeing the tissues. Of course, you all know bone scans for tumor and infection, DEXA scans for osteoporosis. Discography was one thing which we were doing in the past, but now we tend to avoid going into a disc. But this was a test which used to, a positive test used to reveal that it's a discogenic pain and gives a clue to the surgeon whether he should be doing a surgery. So axial pains, not responding, local tenderness, you can do a provocative discography. You put some dye into the disc, pain aggravates, and this is what happens. Just 1 minute. Just 1 minute. Last one. So this is the take-home message for this lecture, that acute and chronic back pain is not simple pain. It's a heterogeneous pain. It's a mixed type of pain. Very important to categorize a back pain or a neck pain patient into various categories, and a very algorithmic approach should be appropriate. Thank you so much. Thank you very much.
The neck compared to the back?
Facial arthropathy of the neck is rather much more common. I mean, like we see almost equal incidence of facetal arthropathy in the neck, and most underdiagnosed, because we see patients coming persistently with neck pain and you don't find anything on the MRI. You say it's a myofascial pain, do exercises, more pain on exercises. So a simple test of elicitation of tenderness and a diagnostic block helps us in clinching the diagnosis.
I think I have already talked here.
Yeah.
Thank you very much.
Thank you. Thank you.
This is very difficult subject. Everybody has got pain sometime or other. Acute back pain, chronic back pain, back syndrome. Three types. Syndromic pain is different than acute and chronic back pain. Okay, doctor. Before we start rendering, a lot of people give a lot of analysis. One ultrasound, one Lulu, one pregabalin. I see patient, my work is to reduce the medicine and give natural. Exercise, avoid food. AC is a complex cause of pain. If you put AC in winter, 18 degree and AC will all muscle charges of pain. So you first ask, is it hitting its body? You could freeze your body themselves, deep freezing.
Since we are just addressing the problem, I just wanted to ask what is your approach for myofascial pains, and do you like
It's a very important question. Again, as I said, large population is coming for acute myofascial. So obviously the initial thing that the market is a conservative management. Posture, sitting posture, lying posture, and exercises later on.
But yes, myofascial pain is a neuropathic pain, so you have to start them on gabapentin and all. But 2-3 weeks of conservative therapy, if it doesn't help, we use trigger point injections to a great extent. And trigger point injections cool off the muscles. I mean, it is not like they are the cure for it, but they cool off the muscle so that patient can exercise. Ultimately, it is back to the stretching and strengthening the muscles, which is important. But medications, trigger point injections, and then back to the basic.
So what is the role of manual breaking of those muscle knots and all that?
Yes, certainly. I mean, like if it is a lot of pain, I will not recommend a manual one, because that can, it's a spasmodic muscle, and if you do a lot of pressure on that, there will be more fibroid. It has been seen that these trigger points have very high volume of nociceptors, nerve receptors. So if you touch it and disturb it, there will be more hyperalgesia, more allodynia. So not manual, but stretching exercises. So that's why needling, dry needling, wet needling, trigger point injections have come into this just to break the spasm, but not manual stretching and all.
One thing I got there, we are all orthopedics. And nobody talk about weight management in pain. If you have a building foundation stone for 1 story and you make a story of 10-story building, it won't collapse. For a 5 feet height male, 50 kilo, and 5 feet height female, 45 kilo. For every inch you add to your height, add 2 kg. And now you understand how many of you are overweight. And imagine what will happen to your 50 or 60 years of age. If you are planning to 100 years, then you will have 99 or 100% chance of pain. The question is that our body construction like that, we are all going to have pain, definitely. Okay? So I think look after your weight. If you are above 60 years, keep your weight up below 60 kg. Longer you are very lucky, you are like this for 69 kg weight. Okay, last 50 years I'm saying nobody, I see everyday people coming with pain and 3-4 MRI and their lumbar canal little narrow, they operate. I said nothing operation, no operation. I have saved many people from operation because people immediately see a MRI, small disc goes at 65, go for operation. No,
So even after operation, then they come to pain clinic.
So don't rush for surgery. I have backache for 40 years. I have not got an X-ray done on my back. I will not allow anybody to get X-ray done. Right? Thank you.
I am so happy to hear this from you, but most eminent surgeon of the
I
country.
spent 45 years almost here in this building. Okay, thank you. Okay.
Yeah. Good morning, chairpersons. It again gives me great pleasure and it's an honor to be back to my alma mater. I'm extremely thankful to begin with Rajiv, Ramesh, Deepak, and speaking before Professor Mahapatra in itself is a great honor. Can I have my slides, please? So I would be talking today on transforaminal epidural blocks, and just to get a perspective, how many of neurosurgeons are there in this meeting? Can we have, so the bulk of them are, and how many of you do transforaminal blocks? So very limited. And how many of you do transforaminal discectomies? So practically 2 or 3. So I think this lecture would help you not just to quickly learn transforaminal blocks, but also sort of help you to graduate towards transforaminal discectomies also if you wish to. So what I've done today is brought in a mixture of both. Now, transforaminal epidural steroids, what you do is the drug is injected through the foraminal root for blocking the nerve roots along with injecting epidural steroids. And the primary advantage is that the drug is being deposited close to the source of pain. Now what I would like to emphasize here is, as clinicians, I must tell you, making a diagnosis is the most important for all of us, because look, as far as surgery or developing surgical skill is concerned, it is not that difficult. Once, even say at the resident level or the junior most level, if your consultant tells you that go do L5S1 discectomy, most of us would be able to perform. But clinching the diagnosis that in a particular patient, whether the pain is discogenic, fascicle, whether there is radicular component or not, so identifying the source of pain is most important, and this is where transforaminal blocks or these blocks come into play as well. So not just they are therapeutic, they are also of great diagnostic value to us. So what are the indications? Obviously radicular pain, which is secondary to disc prolapse. This is the bulk or bread and butter that we see, and so transforaminal blocks help in that. For lateral foraminal stenosis, post-laminectomy syndrome with radiculitis. Now this again, I must tell you that I myself make a lot mistakes a lot of time. When I do a procedure and the patient is coming back to me with back pain, I just keep on giving him drugs or physio, etc., rather than pinpointing that there could still be a problem there which I haven't identified and resolved. So post-laminectomy syndrome, failed back syndrome, this is becoming more and more common. Again, not just because of bad procedure, but a bad diagnosis as well. So this is very important. Post-traumatic or post-herpetic radicular pain, and then scoli. After I used more of blocks, my surgical rate for scoliosis has really come down, especially degenerative scoliosis. We see degen scoli and we attack the patient, not required, because the patient is an adapted patient. You just need to resolve the pains. So degen scoli, don't rush in for surgery, try blocks first. So quickly to point on the radiology of the lumbar foramen, I've just rotated, each one of my films will be rotated so that you get a perspective of how the patient is lying, the radiology when the patient is lying, that is what is important. So these are oval foramen, the height is 1.5 to 2.5 centimeter, but the important thing is that there is progressive widening of the foramen caudally. This is to our advantage because bulk of our cases is L3 downwards. So this is really good for us. You have more space. Now again, if you look at the MRI, this is another important aspect, that the nerve root is in the superior part of the foramen, and you have a lot of part inferiorly which is free. And when you have a disc prolapse, it is the traversing root which is mostly is the source of pain. Now, another important aspect that we should be aware is the Camden's triangle, or the safe zone for approaching the foramen. So, not going into the detail, this is the Camden's triangle, and most of my blocks would go in here rather than in the upper area. I'll give you the exceptions as well. So, the exception is for L5-S1 root, and the reason is that the ganglion moves towards the spinal canal and a little inferior towards L5-S1. So you can use this area pretty well for L5-S1, though if you are comfortable using the Camden's triangle also, there's no issue. So this is the perspective you will have when the patient is there. Now coming to the techniques, I'll tell you as neurosurgeons, it is not a steep learning curve. You can go back and start doing blocks right away. It's just that you need to have the radiological anatomy in your head. Now there are two approaches that I use. The first is, I have coined these terms myself for my convenience, the parasagittal approach, which is just besides the midline. Mostly I'll do this for L5-S1 in view of the bony restriction of the lateral approach. And I do a far lateral approach, which is my personal preference, which is from the side. And the reason I do it is, for L5-S1, when I do endoscopic discectomies, I don't do a transforaminal discectomy because of the height of the iliac crest. What I do is an endoscopic interlaminar discectomy, where I don't need to drill the L5 lamina at all. There's quite a lot of space, and with a 6mm or a 7mm endoscope, I can very well remove the disc. But higher up, when I do transforaminal discectomy,